Bismillahirrahmanirrahim. Today we will be discussing urogynecology. It's a very important topic for MRCOG Part 2, FCPS Part 2 exams. And we are going to discuss small components of urogynecology. It means that the whole discussion on this topic will be done today, and not only we will discuss the urodynamics but also ureteric injury, the prolapse, and some other sort of procedures like Birch corpus suspension and different other investigations like urodynamic testing, etc., while studying this topic in detail. Okay, so let us start from at the very beginning. Like whenever we study the urogynecology, it is very important to start from the symptoms. Lower urinary tract symptoms can be grouped into three categories: bladder and urethra. We have different symptoms related to the storage, voiding, and post-maturation symptom. The storage symptoms are most common. Then we have voiding symptoms. Then we have maturation symptoms. Okay, and then physical examination. Okay, we do vaginal examination. Pelvic organ prolapse, cuffing or bearing down will make a prolapse more obvious. Anterior vaginal wall cyst or urethral diverticulum, then atrophic or vaginal changes. Topical vaginal estrogen can improve frequency and urgency. Then we do physical examination. Coughing with a full bladder during vaginal examination may demonstrate the stress leakage, and pelvic floor muscle strength assessment through digital palpation is done to confirm the contraction and strength. Then, how would you do the investigation? A urine dipstick should be undertaken in all women presenting with urinary incontinence to exclude urinary tract infection, hematuria, and diabetes mellitus. Then, among the tests, we have dipstick test. If it is positive for leukocytes and nitrate, then we send MSU for MCS, culture and sensitivity. Okay, and it may be negative for either leukocytes or nitrate. Okay, then UTI symptoms needs to be asked. If we have UTI symptoms, send MSU for midstream, culture and sensitivity. Prescribe appropriate antibiotics depending on the results, and send pending results means before getting the actual results we can start antibiotic. Then send MSU for MCS, consider antibiotic pending results. When we have no UTI symptoms, send MSU for MCS. Do not prescribe antibiotics unless there is a positive urine culture. Okay, and UTI is unlikely, do not send MSC for MCS. Then investigation, assessing residual urine. Post-void residual is the volume of urine left in the bladder after voiding, and measure post-void residual volume by the bladder scan or catheterization in women with the symptoms suggestive of voiding dysfunction or recurrent UTI. Use a bladder scan in preference to catheterization. Then, among investigations, we may have bladder diary. Bladder diary is a very important diagnostic tool. It is simple and effective tool for assessing the storage symptoms, and it is recommended in the initial assessment of all women with the urinary incontinence, and a minimum of 3 days of diary covering the variations in their usual activities. Now, bladder diaries record 5 parameters: take and volume of fluid intake. It may reveal an excessive intake of fluid, caffeine or alcohol. Normal fluid intake is between 1.5 and 2 liters per day. Then frequency of voids and voided volumes. Voiding more than 8 times per day is abnormal. More than 1 time per night is abnormal. Frequent small voided volumes with a normal urine output can be due to detrusor overactivity or BPS. Frequent large volume voids are associated with overdrinking or diabetes mellitus. Polyuria is defined as 24-hour urine output of more than 40 ml per kg. Leakage episode, whether leakage was preceded by urgency or precipitated by physical activity or coughing. Okay, now this is the 3-day bladder diary. It is a standard NHS protocol to prescribe the 3-day bladder diary for the patients, especially those who come with overactive bladder, urge incontinence. Okay, and investigations, we will do urodynamic testing that consists of the few tests of a bladder and urethral function in relation to the storage and releasing urine, filling and voiding. And it is composed of uroflowmetry and cystometry. Urodynamic is not required before commencing non invasive treatment for storage symptoms. It is not recommended before surgery in a woman who report only pure stress urinary incontinence symptoms or stress predominant mixed urinary incontinence based on the history and examination. Then, urodynamic testing, uroflowmetry. It tests that measures the volume of urine released, the speed at which it is released, and how long the release takes. To diagnose or exclude the voiding difficulties, patient will be asked to drink water until feel ready to pass urine, then empty bladder on uroflowmeter. A graph of flow rate ml per second against the time second is recorded. Uroflowmetry is followed by bladder ultrasound to measure the post-void residual volume. Okay, so this is the setting in which urodynamic testings are done. Then a normal shape curve, normal uroflow study meter measurements. Okay, peak flow rate, maximum flow, Q max more than 15 ml per second, voided volume more than 200 ml, flow time is less than 30 seconds, residual urine is less than 150 ml. Okay, on the one side we have flow rate in ml per second, on horizontal side we have time in second. Okay, Q max is 7 ml per second, abnormal plateau shape graph and decreased Q max. Okay, so Q max should be more than 15 ml per second, but here it is 7 ml per second, so it is decreased. Okay, now multi-channel filling and voiding cystometry. Before surgery in a woman who have any of the following: arch predominant mixed urinary incontinence or urinary incontinence in which type is unclear, symptoms suggestive of voiding dysfunction, anterior or apical prolapse, and a history of previous surgery for stress urinary incontinence. Now, these are normal urodynamic values, and I recommend you to remember these values by heart. When the first sensation is felt at the volume of 150 to 250 ml, strong desire at 400 to 600 ml, detrusor pressure at less than 15 centimeter of water, detrusor pressure voiding is less than 70 centimeter of water, peak flow rate 20 to 40 ml per second, flow time 15 to 20 second, voided volume 220 to 320 ml, residual volume less than 50 ml. Okay, so this is the picture showing urodynamic testing. Now, multi-channel filling and voiding cystometry. Cystometry is carried out under uroflowmetry. Two transducers are inserted into bladder and rectum. The bladder is filled with normal saline. As it fills, the bladder catheter measures the vesical pressure while catheter measures abdominal pressure. Now, the detrusor pressure is shown by PDET. Okay, now how would you measure PDET or detrusor pressure? That is when we subtract abdominal pressure from vesical pressure. And comments on first sensation to void and maximum desire to void. When the maximum desire is reached, bladder capacity filling is stopped and patient performs various actions like coughing, listening to running water, start jumps. At the end of the filling phase, the patient is asked to void. If voiding abnormality is due to poor detrusor function, low pressure and low flow rate, or obstruction, high pressure, high flow rates. That is urodynamic stress incontinence. Detrusor overactivity is shown in here. Stress test. Excellent method of demonstrating objectively the presence of stress urinary incontinence. Step: catheterization.
Urine sample is sent for culture. 250 ml warm saline instilled into bladder. Leakage noted in sitting and supine position. Net weight gain of 2 gram or more is indicative of genuine stress incontinence. So that is Q-tip test, increased mobility of urethra with incontinence. Stress incontinence, we take conservative managements, pharmacological treatments, and surgical treatments. Among the conservative treatments, we may have pelvic floor muscle training, biofeed, electrical stimulation, vaginal cones. Among the pharmacological treatments, we have duloxetine. Surgical managements include least invasive procedures like urethral bulking agent, invasive like TVT and TOT, and Burch-Colpo suspension. Urgent continence management include lifestyle changes, bladder training for 6 weeks, pelvic floor muscle training, pharmacology including oxybutynine. RCUG guidelines shows that in frail old lady, oxybutynine side effects are intolerable. Loltarodine first line, difenasin, botulinum toxin, 100 unit botulinum toxin A according to NICE. And after prescribing it, we need to review the patient after 6 months. Among the surgery, we may have least invasive and invasive procedures. Least invasive, first choice is dorsal sacral nerve stimulation, second is posterior tibial nerve stimulation. Invasive tests include clamp cystoplasty and urinary diversion. I would recommend you to take screenshot of this picture and study it as a flashcard because it explain the whole management of urge incontinence. And the previous one, this one shows the whole management of stress incontinence. So if you memorize these points, these are sufficient. And management of overactive bladders. Non-surgical management includes lifestyle intervention. Recommend a trial of caffeine reduction to a woman with overactive bladders. So first of all, we would advise the lifestyle intervention. Consider advising women with urinary incontinence a high or low fluid intake to modify their fluid intake. Advise women with urinary incontinence or overactive bladder who have BMI greater than 30 to lose weight. Non-surgical management, behavioral therapy. Bladder retraining, offer bladder retraining lasting for minimum of 6 weeks as first line treatment. What is the technique? Instruct women to void every 1.5 hours during the day. When 1.5 hours is achieved, increased by zero point 0.5 hours and continue with 2 hourly voiding. Allow the normal fluid intake 1500 ml per 24 hours. Medical management. Before starting treatment with the medicines, explain to the woman the likelihood of the medicine being successful. That dry mouth and constipation may indicate that the medicine is starting to have an effect. May not see benefit until she for at least 4 weeks. Okay, may not see benefit until at least for 4 weeks. She is just an error here. Okay, choosing medicine, 3 different drugs like oxybutynine, tolterodine, difenasin are prescribed. Do not offer oxybutynine to the older woman. If the first medicine is not effective or well tolerated, offer another medicine. Offer transdermal treatment to the woman unable to tolerate oral medicine. This is the nice recommendation. Now, choosing medicine. Mirabegron is recommended as an option for women in whom antimuscarinic drugs are contraindicated or ineffective or have unacceptable side effects. Desmopressin may be considered to reduce nocturia in the women who find it troublesome symptom. An intravaginal estrogen is prescribed to treat overactive bladder symptoms in the postmenopausal woman with vaginal atrophy. Refer women who have tried taking medicine but for whom it has not been successful or tolerated to a secondary care setting. Offer a review in the primary care to the women who remain on the long-term treatment medicine every 12 hours or every 6 months if they are aged over 75. Invasive procedure for overactive bladder. Majority of the patient will respond to conservative treatment, and the drug treatment, a minority will continue to explain the lower urinary to complain lower urinary tract symptoms. Offer urodynamics to determine whether the reducer overactive is causing her overactive bladder symptoms. Now, intravesical therapy, botulinum toxin type A injection after a local MDT review, offer bladder wall injection to the woman with detrusor overactivity. Consider treatment for a woman with the symptoms of overactive bladder in whom urodynamic has not demonstrated detrusor overactivity. Explain to the patient the likelihood of complete or partial symptoms relief, the process of clean intermittent catheterization, the risk of adverse effects, including the risk of increased urinary tract infection, that there is not much evidence about how long the injections work for. Use 100 unit as initial dose of botulinum toxin type A. Offer face-to-face telephone review within the 12 weeks of first-line treatment. If there is good symptom relief, tell the woman how to self-refer for prompt specialist review if the symptoms return. If there is inadequate symptoms relief, consider increasing subsequent doses to 200 units and review within the 12 weeks. If there are no effects, discuss with the local MDT. Neuromodulation, percutaneous sacral nerve stimulation, permanent implantable devices in the S3 sacral foramina, and after MDT review, offer percutaneous sacral nerve stimulation to the woman if their symptoms have not responded to the non-invasive management and their symptoms have not responded to botulinum toxin type A, or they are not prepared to accept the risk of needing catheterization associated with botulinum toxin type A. Reconstructive surgery. Augmentation cystoplasty, bladder is bisected almost completely and a patch of the gut equal in length to the bisected bladder is sewn in place. Restrict surgery to the woman not responded to non-surgical management and willing and able to self-catheterize sometime permanently. Discuss common and serious complication: bowel disturbance, metabolic acidosis, mucus production, UTI, urinary retention, and small risk of malignancy. Urinary diversion as a last resort. All the management failed and the woman cannot manage the clean intermittent catheterization. Ileal conduct to create a stoma for urinary diversion and that provide a lifelong follow-up. That we need lifelong follow-up for that. So that is the what I was explaining, that the urinary diversion ileal conduct. Okay, and management of stress urinary incontinence. Again, I would like to say that we have lifestyle intervention. Advise women to modify their fluid intake. Advise women who have BMI greater than 30 to reduce the weight. And pelvic floor muscle training. Patients should undergo supervised pelvic floor muscle training of at least 3 months before surgery, and it comprises of 8 contraction performed 3 times per day. That is very important. And how it is done: women learn to pre-contract the pelvic floor muscles before and during. Increase abdominal pressure to prevent leakage, and patients who do not respond to the treatment or have prolapse and should be referred for secondary care in 50% of the cases. Medical therapy: duloxetine SNRI. It is used in the treatment of depression and is the only drug licensed for the treatment of stress urinary incontinence. Should not be used as a first line treatment or a second line treatment for stress urinary incontinence. May be offered as an alternative to surgical treatment. Consult the woman about the side effects that include the nausea, constipation, dry mouth, disturbed mood. And the most effective way of curing stress urinary incontinence, up to 90% cure rate. And surgery aims to elevate the bladder, neck, and proximal urethra into abdominal position to increase the outflow resistance. If non-surgical management of stress urinary incontinence has failed, offer the choices of corpus suspension or laparoscopic autologous rectus facial sling, retropubic mid-urethral mesh sling. And retropubic space is dissected until wide paravaginal tissue lateral to the bladder neck is exposed and 4 pillars of non-absorbable or long-term sutures are inserted between the fascia and iliopectineal ligament. Now, retropubic space is dissected until a wide paravaginal tissue lateral to the bladder neck is exposed and four pillars of non-absorbable sutures inserted between the fascia and iliopectineal ligaments. Complications include the voiding difficulties. These are most common and usually resolve with a short time. If they persist, the patient may need to carry clean intermittent self-catheterization, urgency or urge incontinence may another complication. Maybe another complication. And retropubic mid-urethral meshing procedure advised the woman that it is permanent implant and complete removal might not be possible. Use bottom-up approach with a colored macroporous type 1 polypropylene meshes inserted transvaginally with two suprapubic exit points. So bottom-up approach, that is important point. Limited evidence on the long-term adverse effects. Okay, so that is what I was explaining. Intramural bulking agent, macroplastic, bulkamide injection into submucosal tissue of the urethra or bladder neck increases flow resistance. Permanent injectable material. Repeat injections may be needed to achieve effectiveness and less effective than surgery. Effects wear off over time. Artificial urinary sphincter, it is the treatment of last resort. Artificial urinary sphincter allows to control bladder with a hand operated pump to compress and release cuff around the urethra. Then follow-up after surgery, offer a follow-up appointment within the 6 months. Retropubic mid-urethral meshing surgery, vaginal examination to check for the exposure or extrusion of the mesh slings, and Birch-Corpus suspension. That is what I am going to explain. Retropubic space is dissected until a wide paravaginal tissue lateral to the bladder neck is exposed. Four pillars of non-absorbable or long-term sutures are inserted between the fascia and iliopectineal ligaments. Now, position is modified lithotomy position using the Laird Davies stirrup. And the procedure, Foley's catheter is inserted. Okay, and transverse incision just above phalansteal is given. So that is what you see, and these type of sutures are placed. Tying sutures on the lateral sides of vaginal fornices in the birch. Post-operative care, we need to provide them. Post-operative complications, voiding difficulties, testosterone overactivity, and enterocele. So POPQ classification is another very important component of urogynecology. So first of all, let us emphasize on different points like capital A, small a. Okay, so capital A, small a, anterior vaginal wall 3 cm proximal to the hymen, minus 3 cm to plus 3 cm. Minus 3 cm means up, above the hymenal ring, and plus 3 cm means below the hymenal ring up to 3 cm. So that is point AA. Okay, now a BA, most distal position of the remaining upper anterior vaginal wall, minus 3 cm to plus TVL, minus 3 cm above to plus TVL. So that is the point BA. C, most distal edge of the cervix or vaginal cuff scar. So that is point C. That was point C. Okay, and this is the point D, which I am going to explain. Before that, it was point C. Okay, so that is point C, vaginal cuff, and that is point D, somewhat related to posterior ductus. Posterior vaginal fornix not applicable if post hysterectomy. And AP, posterior vaginal wall 3 cm proximal to the hymen, minus 3 cm to plus 3 cm. BP, B of the posterior. So BP, most distal position of remaining upper posterior vaginal wall, minus 3 to plus TVL. Okay, now TVL, genital hiatus, perineal body. Okay, genital hiatus and perineal body. Genital hiatus is the distance from midline of external urethral meatus to midline of posterior hymenal ring, and perineal body is the distance from posterior margin of genital hiatus to mid-anal opening. Genital hiatus measure from middle of external urethral meatus to posterior midline hymen, and perineal body is measured from posterior margin of the genital hiatus to middle of the anal opening. Total vaginal length is the depth of vagina when point D and C is reduced to the normal position. POPQ staging criteria. Okay, so POPQ landmark is the hymenal ring. Okay, hymenal ring 0 above negative and below positive. Hymen 0 above proximal to the hymen negative, below distal to the hymen positive points. Okay, so that is a sort of grid. We make certain lines, two horizontal line, two straight lines, to make total 9 boxes, and you can see the position of each AA, BA, C, genital hiatus, perineal body, total vaginal length in the middle portion, and then we have posterior AP, BP, and D. So in this way we explain the grid, and it is internationally recommended. Okay, so what happens in stage 0? Stage 0, the normal position. AA, AP, BA, BP minus 3 centimeter, and C or D less than total vaginal length minus 2 centimeter. Okay, and what happened in stage 1? Stage 0 criteria not met, and the leading edge is less than minus 1 centimeter. Stage 2, leading edge more than minus 1 but less than plus 1 centimeter. Stage 3, leading edge more than 1 centimeter but less than plus TVL minus 2 centimeter. Stage 4, leading edge is more than TVL minus plus TVL minus 2 centimeter. Plus TVL minus 2 centimeter means that length is beyond or below the hymenal ring, so plus sign is used. Okay, so that is the whole explanation. Stage 1, 2, 3, and 4. Stage 0, no prolapse. Stage 1, more than 1 centimeter above the hymenal ring. Stage 2, minus 1, 2, plus 1. Then comes the hymenal ring. Stage 3, plus 1, 2, plus TVL minus 2, and stage 4, more than TVL minus 2. Thank you so much for your kind listening. I tried to explain important points related to urogynecology, and this video will give you an overview about each and every component. Thank you so much for your patience. Allah Hafiz.